The following podcast is part of a certified educational activity titled Moving the Treatment of Advanced Gastroesophageal Cancers Forward. How can we maximize the benefits of novel immunotherapy approaches? Access the entire activity and complete the post-test at peerview.com/NTS860. Downloadable slides and practice aids are also available.
Hello and welcome to our program. My name is Dr. Yelena Janjigian. I'm a medical oncologist and Chief of GI Oncology Service at Memorial Sloan Kettering Cancer Center in New York City. I'm joined today by my colleague at Memorial, Dr. Steve Marin, who is also a medical oncologist focused on GI cancers. And today it's a pleasure for us to discuss with you updates and how the treatments for advanced gastroesophageal cancers have moved forward to help you maximize the use of these agents in standard practice, particularly for novel immunotherapy approaches. We'll start with Module 1, which is realizing the potential of novel immunotherapy options for patients with advanced gastroesophageal cancers. By way of background, immunotherapy has transformed the field of upper GI malignancies, and we will start with adenocarcinomas. Nivolumab is approved in combination with chemotherapy in the United States, Canada, and many countries worldwide in first-line treatment, irrespective of PD-L1 status. Pembrolizumab is also approved in combination with trastuzumab and chemotherapy in first-line setting, specifically for HER2-positive disease. We also still have the approval of nivolumab in Asia in later lines of therapies beyond second and third line therapy. However, that approval has been withdrawn and we no longer have anti-PD-1 therapy in the United States. Pembrolizumab approval in third line or beyond was withdrawn as of July of 2021. We still have pembrolizumab, however, for TMB high and MSI high patients. So we'll start with the practice-changing CheckMate 649 study. This was a large phase 3 study randomizing patients, over 2,000 patients, irrespective of PD-L1 status. Both esophageal, G-junction, and gastric adenocarcinoma patients were included across 4 arms. Chemotherapy arm was compared to chemotherapy plus immunotherapy, and then the third arm of CheckMate 649 included nivolumab, ipilimumab. The primary endpoint for the study was the overall and progression-free survival in patients selected by PD-L1 CPS 5 or greater. And this was the pre-specified primary endpoint. Hierarchical tested secondary endpoints included all intention to treat population and PD-L1 CPS 1 population for OS and PFS. Another hierarchically tested secondary endpoint was for nivo-ipi in secondary analysis. And this arm was actually closed early due to increased toxicity and deaths relative to the other 2 arms. So when we look at CheckMate 649 data, what led to the FDA approval are these survival curves right here. This data has been published in Lancet, and since then the analysis has been updated in Nature. So looking at the left, we look at the primary endpoint, which is CPS 5 or greater. The hazard ratio is 0.71. For the first time in pretty much ever, we see the median overall survival for HER2 negative population cross the 1-year mark, so median OS of 14.4 months for biomarker selected population. And in all randomized, all-comer patients, CPS, regardless of CPS, OS is 13.8 months. So the hazard ratio is less robust than for biomarker selected population, but the survival curves are similar in shape, and there is a nice plateau on the curve, suggesting that there is a benefit irrespective of PD-L1 in some population as well. It's important to note that the population of CPS 5 greater patient is the predominant population here. It's 60% of the population, and that's why the survival curves look like that. Well, this is the long-term follow-up. The 2-year follow-up has shown that close to 30% of patients are alive at 2 years, again, suggesting long-term benefit. And some of this benefit is seen as irrespective of PD-L1 status. Directionally, the hazard ratios actually improved and became smaller. So the hazard ratio of 0.7 with long-term follow-up and 0.79 for all comers here, median OS 13.8. So it's nice to see this long-term survival data, and it's certainly very important for our patients. Well, what about response and response duration? especially looking by difference in PD-L1. For CPS5 or less than CPS5 population, we all agree that perhaps this population of patients benefit less in terms of survival benefit. The overall response rate benefit is still there, although less pronounced. It's about 10%. For CPS5 or greater, the overall response rate improvement is at 15%. The median duration of response is improved irrespective of which population. So highlighting the importance of use in first-line setting. The depth of response, as seen on these waterfall plots, is improved in all randomized patients. 24% of patients had greater than 80% reduction in targeted measurable lesions with addition of nivolumab compared to 17%, and it's 27% for PD-L1 CPS5 versus 19% for CPS less than 5. So the depth of response can potentially be augmented. Here it's 19% for CPS less than 5 for nivo chemo, 13% for CPS less than 5 had a deep response for chemotherapy alone. What about MSI status? Well, later on in the program, Dr. Marin will talk more about subsets that benefit the most from immunotherapy, and MSI population is one of those. So hazard ratio of 0.38, whether or not you receive immunotherapy in first-line setting, overall response rate is improved. And this is critical, particularly if you're considering restricting use of immunotherapy based on PD-L1 status, because MSI and PD-L1 overexpression sometimes go hand in hand, but not always. We do see some MSI patients with PD-L1 CPS less than 5. What about nivo-ipi population? As I mentioned, that study, that arm was closed early. The secondary endpoint was not met. The hazard ratio is 0.89, but it crosses the 1 mark. Median overall survivals are very similar. And because we see this initial detriment and crossover in favor of chemotherapy for the first 12 months, even though there's a plateau on the nivo-ipi arm, the plateau is just not significant enough to justify use in first-line setting. Response and duration of response, however, with nivo-ipi, if you do respond to nivo-ipi, your duration of response is doubled. Overall response rate is actually quite similar, 27% in later line therapy, which is what we saw in CheckMate 32, versus first line therapy, which is what we saw in CheckMate 649, suggesting there's a subset of patients that will benefit from nivo-ipi, perhaps beyond MSI and EBV patients. However, that's not usable in standard practice because of the risk of adverse events and potential detriment outside of a study. For MSI patients, however, it's small numbers, only 11 patients treated with nivo-ipi. Overall response rate is 70%, hazard ratio is 0.28. Again, the duration of response is doubled. So for this population of patients, again, highlighting the importance of immune checkpoint inhibitor, know who your MSI patients are, test them early, test them even in early stage setting because it has implications in perioperative management as well. And it's critical to know in stage 4 disease because of use immune checkpoint blockade. Here for CheckMate 649 data, again, this is important subset of analysis, but highlighting the importance of realizing what are the primary endpoint, which is CPS5, what is the subset analysis, which is not pre-planned and retrospective. So the cutoffs using CPS less than 1, greater than 1, suggests that absolutely higher PD-L1 patients benefit the greatest, with the caveat that it's a dose-response relationship, and how certain are we about calling a tumor CPS 3, 4, 5, and so forth after a certain point. It's very operational dependent, quality of the sample, tumor content, the amount of time that the sample has been sitting there in a pathology lab. All of these are drivers of heterogeneity and the difference in testing. So the FDA actually, and many different countries, approved the use of immunotherapy irrespective of PD-L1 status. The EMA and NCCN, for example, list this as the use of PD-L1 CPS5 is the preferred cutoff, and the NCCN specifically lists all-comer use as a Category 2B recommendation. So a lot of it is, it's nice as a clinician to have the power to decide whether or not to offer these medications to your patients, and a lot of detail goes into subsequent biomarker testing, and PD-L1 is an important part of this. The reason why we weigh risk benefits is because when you add immunotherapy to chemotherapy, there's increased rate of adverse events. It's approximately 15% increase in grade 3-4 events. The reason why is because you have chemotherapy side effects and you add them immune check blockade side effect. And so, you get a bit of both. Most side effects include elevation in grade 3-4 events such as liver function tests or neutropenia, and neuropathy, diarrhea, and so forth. We included this slide just to give you a sense of the complexity of the field. In the interest of time, we covered some of the main studies, but Attraction 4 is an important study as well that looked at this population, Asia population, and demonstrated progression-free survival, but not overall survival benefit. So something for you to be aware of. And coming out of Asia, we have many more anti-PD-1 therapies that are available. In the interest of time, again, we weren't able to summarize them, but what the Asian data does help us with is this question of what is the rate of CPS 5 or greater, what should be the rate in standard practice. Often you hear from the clinicians that 60% of CPS 5 or greater feels like too high of a number. That's not what I'm seeing in my clinic. And what we see in phase 3 studies is across 2 or 3 more studies now, and this is, I just summarized it, Orient 16 and Checkmate 649, using different antibodies, because Checkmate 649 is used DACO 28.8, Orient 16 is used 22C3. 60% positivity is what you should expect in practice using CPS 5 or greater cutoff. And if you're seeing anything less, question the methodology of how the test is being done, question on the quality of the sample, the tumor content, perhaps all the other factors that are associated with it. And that's why often in the real world, I feel uncomfortable restricting use of immune checkpoint blockade, because I think we are underestimating the percent of patients that could be eligible for those therapies. Last but not least, for the adeno cohorts is the Keynote 811. This was a large phase 3 study that finished accrual. The survival data is still maturing, but patients were randomized in first-line setting, irrespective of PD-L1, based on HER2 positivity, so IHC3+ or IHC2+ FISH positive, to receive pembrolizumab plus trastuzumab and chemotherapy, which is oxaliplatin-based therapy, versus placebo plus trastuzumab and Capox. And the interim analysis was based on overall response rate. We were expecting a very high overall response rate based on the MSK phase 2 data that led to the phase 3 study. Here we see the overall response rate, which has not been previously demonstrated in any phase 3 study, of 74% with a delta of close to 23% compared to the standard of care. The depth of the response was nearly double. Decrease of greater than 80% was seen in 32% of patients with pembrolizumab, trastuzumab, versus 15% in the standard of care arm. The FDA was very impressed with this data, and it led to the approval of May of 2021. So it's available in your clinic. The grade 3, 4, and 5 adverse events did not differ between treatment arms, so this is a very safe regimen. And can be used in standard practice in the United States. It's already available. So this was a whirlwind a summary of adenocarcinoma data, and now it's a pleasure to invite my colleague, Dr. Steve Marin, to summarize the squamous data and the updates. Please, Dr. Marin, go ahead.
Okay. So Dr. Janjigian already spoke about adenocarcinomas in terms of where immunotherapy fits into our paradigm. But the next piece is looking at esophageal squamous cell carcinomas. And so really this data is based upon the first-line Keynote 590 trial. And this was patients who had esophageal cancer that was either adenocarcinoma or squamous cell carcinoma, though primarily esophageal squamous. They had performance status of 0 to 1, they had to be treatment naive. And then they were stratified by whether they were in Asia versus non-Asia, by their histology, and also by performance status. And patients received chemotherapy either with pembrolizumab or placebo. And in Keynote 590, there are a few key points from the data. First, there was absolutely an overall survival benefit, but this was really much more profound than specific subsets of these patients. Primarily, the patients who had esophageal squamous cell carcinomas, and within that group, this is most profound in the patients who had a CPS score of 10 or greater. And we'll talk about CPS scores in just a moment. There was also an objective response benefit for this subset of patients. And as I alluded to, when you look in these subsets of the squamous cell carcinomas, as well as those with the CPS greater than 10, you can see the improved 12-month and 24-month survival rates. On both the left, looking at PD-L1 CPS, on the right, across the squamous cell carcinoma patients. And then when you look at the multivariate analysis, you can see that patients benefited really regardless of histology, but this is primarily seen in those with squamous cell carcinoma, and you're seeing the greatest benefit in those with a CPS score of 10 or greater. But more recently, there's data from Checkmate 648. And so this is a first-line combination specifically in squamous cell carcinoma of the esophagus. And in this trial, patients received either chemotherapy with nivolumab, chemotherapy without nivolumab, or nivolumab and ipilimumab in a chemo-free regimen. And again, there was stratification by PD-L1, but one key point here is this is by TPS score, not CPS, by region again, performance status, and then the number of organs that were involved. And in the results for Checkmate 649, on the right, we're looking at patients across the entire trial, where you're seeing a more modest benefit. And then when patients are stratified by TPS score, using a cutoff of 1 or greater, we see a much more profound overall survival benefit here. But even more recent data presented in 2021 with nivolumab and ipilimumab. And what you're seeing on the right, again, is across the entire cohort, a rather modest but statistically significant survival benefit. And on the left, in that population that had a TPS score of 1 or greater, we are seeing a more profound overall survival benefit. And when you look at the durations of response across these three arms, again, you're seeing actually similar durations for nivolumab plus chemotherapy versus chemotherapy alone when you're looking across the entire intention to treat population. Surprisingly, a little longer in the nivolumab plus ipilimumab, but this is in a smaller subset of patients that had already responded. And then you see these numbers do increase somewhat for the PD-L1 1% or greater for the nivolumab plus chemotherapy and the nivolumab plus ipilimumab, but not as much, or frankly not at all, for the chemotherapy only arm. In terms of safety signals across these three arms, there's a very high rate of any toxicities and rather similar rates of toxicities amongst the two chemotherapy containing arms. But what is most notable here is the nivolumab plus ipilimumab grade 3-4 toxicities that were seen in about 23% of patients, even without the chemotherapy present. And so whenever we're using combined therapy with CTLA-4 inhibition, we have to be mindful of the additional toxicity from the CTLA-4 inhibitor, in addition to the PD-1 inhibition. But from there, we're going to switch gears a little bit and discuss the molecular features of this particular cancer to get a better understanding of why we see responses in some groups more than others and how we can identify which patients these will be. And so when the Cancer Genome Atlas sought to stratify these patients into histological subtypes, the first group was the esophageal squamous cell carcinomas on their own. These were characterized by CCND1 amplifications, TP63 and SOX2 amplifications, and KDM6A deletions. Then you have the chromosomally unstable cancers. This represents the bulk of the esophagogastric cancers that we see in the United States, typically localized at or around the GE junction. And these are the patients where you'll find most of the early 2 amplifications, those HER2 positive cancers, also frequent VEGF amplifications, and nearly all these patients have TP53 mutations. And then we get into the smaller subsets that are typically found in the stomach. First, you have the 2 that are very responsive to immunotherapy, that is EBV positive tumors that are typically characterized by PIK3CA mutations and very high PD-L1 expression typically. And you have the microsatellite unstable cancers. And the way you recognize these is really seeing a very high tumor mutation burden. They too are typically PD-L1 quite positive. And this could either be due to underlying Lynch syndrome or MLH1 promoter hypermethylation, which is typically more common in older patients. But the last subtype that we haven't really talked about today are those with genomically stable tumors, also called diffuse type or signet ring cancers frequently. And these are the patients who typically have loss of CDH1, whether inherited or acquired. They have frequent ROA mutations, and they also do have frequent Claudin 18 fusions. And so by thinking of it in this way, we could better stratify which type of therapy would be better for which patient. And to look at the overall landscape across esophageal gastric cancer, its pie chart tells us a lot more about where we're at now and where we're going in the future. And we know about 15 to 20% of patients can benefit from HER2-directed therapy. We now have approvals for chemotherapy plus trastuzumab plus pembrolizumab in the first line, as well as trastuzumab deruxtecan in later lines. For the 3 to 5% of patients who have microsatellite unstable tumors, we know that they respond incredibly well to immunotherapy PD-1 inhibitors, typically on the order of about 60%. For PD-L1 positive patients, I'll talk a little bit more about this in terms of the level of PD-1, PD-L1. And then we have more investigational biomarkers. We have Claudin 18.2, which is found in about 30 to 35% of patients for the fast trial with zolbetuximab. And more recently, the data from the FIGHT trial looking at FGFR2 amplification and or FGFR2 expression by IHC, which can be found in about 30% of patients. And so this is really a rapidly evolving landscape where we're able to target Claudin 18.2, FGFR2b in clinical trials, other clinical trials looking at targeting other oncogenic amplifications, namely MET and EGFR.
Stephen, so in an increasingly crowded space of biomarker testing in your clinic, how do you prioritize these?
That's a great question. As standard of care in all of our patients that we see with esophageal gastric cancer, I always want to know their microsatellite instability testing, their HER2, and their PD-L1. When tissue is available, absolutely in the stage 4 setting, and sometimes earlier as well when patients have a very high risk of recurrence, like in stage 3, I do tissue testing with MSK Impact at our institution, which will look at about 500 different genes looking for mutations and amplifications that are potentially actionable in the future.
And what about germline testing and circulating tumor DNA? How do you think about those?
That's a great question. As part of this, we actually do matched normal blood collection as well to look for germline alterations. And in conjunction with family history, we really do find quite a few patients who have germline alterations. So I find it very worthwhile to look for this, both for the patients and their family members. Now, I mentioned PD-L1 expression by IHC a few times now. And whereas some of the slides refer to the tumor positive score, we now use a cell positive score, or CPS, which is counting the number of PD-L1 staining cells, both tumor cells and immune cells present, divided by just the tumor cells that are present and multiplying them by 100. And so it can actually be a number greater than 100 sometimes. And you could see on the left a negative sample, on the right a very positive sample where you're seeing a lot of brown showing the membranous staining. But it's a difficult biomarker to use. Nearly every company and most cancers has used a different antibody with a variable cutoff, and you'll see differences between patients, within the same patient, and across time. And what we find is that the negative predictive value of this biomarker is quite useful, but the positive predictive value remains quite low. And so further biomarkers are needed. And one study that was published that I actually found quite interesting was looking at in patients who were tested across time, so pre-treatment and post-treatment, or primary versus metastasis. And they found that there's a significant discordance even within the same patient between PD-L1 tests, and this was all at the same institution. It just highlights how much variability there is depending on the biopsy, depending on the site, depending on the time, and how we have to be mindful of when it's proper to use immunotherapy or not in these patients in the setting of a pan approval now. And so with that, we're going to transition to the next piece, but Dr. Janjigian, Going back to what we were showing before with Checkmate 648, we now have this evolving landscape, right? Where we have this option of chemotherapy versus chemotherapy with PD-1 inhibition that most profoundly in select patients versus now a chemotherapy-free backbone. When do you think about using nivolumab with ipilimumab?
It's a great question, and it does come up, especially from patients' perspective. Chemotherapy-free backbone often is an attractive option. The good news is Checkmate 648 used IPI-1, so lower dose of IPI, and overall the tolerability was fine. The grade 3-4 events was acceptable, although the serious grade 3-4 events in that study was higher with nivo-IPI compared to chemo-nivo. The big question is, how does nivo-IPI directly compare to chemo plus immunotherapy, either on Keynote 590 or Checkmate 648? And it's hard to know because those numbers were never directly compared. What we do know, similar from adenocarcinoma and to squamous cell cancer, there is an initial crossover in favor of chemotherapy in all the studies that do not use chemotherapy in combination with immunotherapy. So that's my concern with Checkmate 648 population. We know that people that go on phase 3 studies typically are a fitter and more robust population. In my clinic, when a patient comes in with squamous cell cancer, they're usually frail and have large disease burden. They need a quick response. And so that's the concern with nivo-IPI, is the response quick enough? I think the duration of response once the patient is response is great. Realistically, most of my patients in the clinic, squamous cell patients, need chemotherapy plus immunotherapy. And the population of patients that I would consider using immunotherapy without chemo are the small volume disease patients, relatively asymptomatic from their cancer. Would you agree?
I completely agree. And it is always difficult to make that choice and look forward to having more options in this space really for our patients. Why don't we talk about some cases to really work through this data a bit more?
Great. What do we have?
Looks like we have these here in module 2. Okay. So we have a male oil refinery worker, 6'2", with mild dysphagia for 5 months and a 5-kilo weight loss, whose PCP ordered an EGD, revealing a GE junction mass that was consistent of a poorly differentiated gastric adenocarcinoma with signet rim cells, with 2 liver lesions present and a large gastrohepatic nodal mass and thickened GE junction. This goes back to our question before: which biomarkers tests would you order to guide treatment?
Yeah, so this is a very typical presentation, right? And the number one predictor of the outcome is the amount of weight loss the patient experienced, what their functional status is, how well they can tolerate therapy, and nutritionally how you can best support them. So that's your first decision tree point, right? Is this patient fit for treatment? How aggressive can I be? The second question that often comes up is, do I need to biopsy these liver lesions to confirm metastatic disease? Typically, we don't require biopsies, even for clinical trial enrollment of the metastatic lesion, as long as there's at least 2 different radiographic modalities that confirm that this is consistent as M1 disease. So for our patients, it's typically high-resolution CT scan and a PET scan or an MRI you're really certain that this is adenocarcinoma from the endoscopy and radiographically metastatic disease. What we do know from the biopsies is that typically there's plenty of tissue to do biomarker testing, especially in first-line setting. So don't be shy, test away. I completely agree with you. We do prioritize HER2 and MSI. MMR, IHC is very important to do for these patients, HER2 IHC, and PD-L1 as well. In addition to that, in our practice, we standardly do Epstein-Barr virus testing, as it may have implications in de-escalation of chemotherapy. And certainly, as we discussed before, both germline and tumor mutation testing. Steve, would you check ctDNA in this patient at baseline?
In my practice, I typically do. I often do check ctDNA in conjunction with tissue testing, and we've looked at this before because we find an incredible amount of heterogeneity between the primary tumor and the metastatic sites. And oftentimes that it allows you to both identify more actionable targets while also characterizing the amount of heterogeneity, which is actually prognostic in terms of how much benefit they'll get from, let's say, a HER2-directed therapy. How about in your practice, Elena?
That's a good question. And typically, if there is a targetable alteration, such as HER2 or MSI, then I do follow ctDNA. If this is a straightforward case with no targetable alterations, I don't check because it's similar, I guess, to tumor markers. They're useful, but may not be um, that useful in the fluctuations. Do cause a lot of anxiety, and also the timing of the switch of therapy and so forth. So unless there is a clonal sort of evolution or any interesting lessons to be learned, or if a patient is in a clinical trial, I don't routinely check ctDNA in all stage 4 patients.
You actually brought up a great point. There are two times where I really try not to check ctDNA. One of which is if somebody comes to me and they've already started therapy, I worry about the false negatives of testing ctDNA during therapy. That's right. And two, if they're not on a targeted therapy and they've already had testing that did not reveal any actionable alterations, the odds of developing a new actionable alteration are quite low.
Yeah. Yeah. Monitoring it just to know the tumor burden and the changes in the max VAF, I think really perhaps it would be helpful in the future if we have better effective strategies where we can potentially switch treatment before even clear radiographic progression. Unfortunately, for now, I know what second-line Taxol or ramucirumab can do, and it's not, doesn't warrant early switch, I think, unless there's clear radiographic progression. So what happened to this patient? Let's see.
Let's see. His cancer came back HER2 negative, PL and CPS 7, microsatellite stable, tumor mutation burden 5, KRAS amplified, and with a TP53 mutation. So what treatment option will you consider?
So are you surprised about this profile, or is this pretty typical?
I'm really not surprised at all. So when I saw signet ring cells, so it could be suggestive of focal signet rings. It could be signet ring cell carcinoma. It's a biopsy, so I can't really definitively answer that. If that is the case, that it was a signet ring carcinoma, I would expect it to be HER2 negative. I would actually expect a CPS 0 in a case like that, and probably even a lower TMB than it was. Probably not the KRAS amplification. So it seems more like a typical focal signet ring type cancer, where the location is with TP53 mutation, KRAS amplification, seems like a chromosomally unstable G junction adenocarcinoma to me. So I would call that sort of our bread and butter.
Agreed. Yeah, and KRAS amplifications are not targetable, as you mentioned. When I get these cases, I'm always curious as to which antibody was used for CPS testing, particularly if it's a PD-L1 negative case. There are many different clear approved antibodies, and you have to read the fine print and understand how it was determined, if it's and what the CPS score. But this is bread butter. Unfortunately, mainstream G junction cancers, most of them are HER2 negative and p53 mutant. So.
And what are your thoughts in terms of CPS 1 plus, 5 plus, and 10 plus for checkmate versus keynote?
Yeah, it's tricky because again, I think it's important to continue to test, and it's important to risk stratify. So, for example, if this patient was older or frailer or had maybe adverse events associated, a particular risk for adverse events associated with immune checkpoint blockade, and their tumor was less than 5, you could talk about the risk-benefit ratio of using immunotherapy in that setting. Certainly, we know there is a gradient of benefit, and it's a continuum, and I think it's important to understand where to draw the line and when to treat the patient or not, and how certain you are about the result that you're reporting to the patient with the CPS scoring. I don't feel comfortable saying that we can, with laser precision, tell if the tumor is CPS 1, 2, 3, or 4, or 5. I think it's overstating the reliability of this test, but reporting it in sort of general terms of the risk-benefit ratio. We know that if CPS is greater than 10, the benefit is obviously much more robust. For 5 to 10, it's intermediate. Less than 5, it's less.
I think that's a great way of putting it. Just like everything else in medicine, having that risk benefit discussion with the patient, right?
Yes.
Let's see what's next. So how are we going to treat this gentleman? Chemotherapy of platinum and fluoropyrimidine, chemotherapy of platinum, fluoropyrimidine, and taxane, it's a flat scenario, or chemotherapy of platinum, fluoropyrimidine, and nivolumab.
Yeah, so even before Checkmate 649 approval, I rarely used a triplet therapy in this population. The population of patients that I did use FLOT type regimens or modified DCF were the young, fit patients. By young, I mean less than 50, who are presenting with large disease burden, where I was worried that if I didn't get the disease under control, we would never use second-line therapy in those patients. It is not the 68-year-old with weight loss and who can't eat, who has only 2 liver mets. Those patients get hurt potentially with triplet therapy. And now you don't have to do it because we have immunotherapy approved. So for those patients, fluoropyrimidine with oxaliplatin combination. Cisplatin should not be used in standard practice at high doses. It's very toxic. And now Keynote 811 and Checkmate 649 used oxaliplatin. So that's the new registration regimen. So 5-FU, platinum, and nivolumab is what I would use. This case made it easy for us. It's CPS 7, so this is in agreement even with EMA and the NCCN guidelines. Would I use nivolumab in a patient with less than 5 PD-L1 overexpression? We do discuss these in the clinic, and we have several trials for these patients, so I think that should be your answer. And then you can decide on case-by-case basis. I typically do offer them immunotherapy if they understand the risk-benefit ratio.
And that really is an advantage of being where we are, in that even with the wonderful benefits we're seeing with adding immunotherapy per these trials, we really do need to do better still. And so I agree with you that clinical trial is always the best option available. But why don't we change the scenario just a little bit here? So now let's say this patient is a retired teacher with stage 4 GE junction adenocarcinoma. It's metastatic to the lungs. 2 children, 3 grandchildren, microsatellite stable tumor that is HER2 positive now. CPS positive. Or heck, we could even say CPS negative here with a good performance status. What would you give them?
Yeah, well, he hit the jackpot. HER2 positive is a really the silver lining of having this disease. So for these patients in particular, it's very important now to consider doing NGS, because I do find knowing the co-occurring alterations with HER2 very helpful. And actually for those patients, I think circulating tumor DNA may be an easier way to get a understanding of the spectrum of the tumors. We know HER2 positive tumors are not all created equal. If you have high level of amplification in circulating tumor DNA or even in tumor by NGS, those patients tend to do much better on first-line HER2-directed therapy. And addition of pembrolizumab, irrespective of PD-L1 status, dramatically improves overall response rate. The overall survival is not yet mature, but in the phase 2 setting, it was overall survival surpassing 2 years, the median overall survival. So in the United States, many have started to use this combination even after the phase 2 data published in Lancet Oncology, and now it's approved in phase 3 based on phase 3 setting. So it is really important. But it's funny that you highlighted the CPS testing. Tell me, what do we know about PD-L1 and CPS and as a mechanism of resistance to trastuzumab, and how we should think about it when it comes to HER2?
This is one of the most incredible translational pieces of this paradigm, in that there's actually no benefit shown for patients who are CPS 1 or greater versus CPS 0 when it comes to HER2-directed therapy in conjunction with PD-1 inhibition. We don't really know the mechanism at this point, but it's possible that there's a synergy between the pembrolizumab and trastuzumab such that PD-L1 testing really doesn't matter in this population. I would use this combination therapy regardless of their PD-L1. And I think that's an important point.
Absolutely.
One other logistical issue I've run into in my practice is that the original way that this is tested is with Capox, with pembrolizumab and trastuzumab, using pembrolizumab and trastuzumab every 3 weeks. However, many of my patients are coming in quite obstructed, unable to take capecitabine. How are you handling this in your practice in terms of how to dose these patients from the beginning?
That's a great question. And so there's two ways you can think about it. You could consider doing pembrolizumab off, doing FOLFOX and then pembrolizumab, every 6 weeks, FOLFOX trastuzumab every 2, and pembrolizumab every 6. You could consider doing pembrolizumab every 3 weeks on 1 week off, from the every 2 week schedule. Practically, I have been able to get FOLFOX, nivolumab, pembrolizumab for those patients as well. So there's options. The good news is the swallowing often improves after first or second cycle, so it becomes less of an issue. But I agree with you, capecitabine is not for everyone. On this, in Checkmate 649 study, it was a 50-50 use between Capox versus FOLFOX typically.
It's nice to have that flexibility when sometimes we're able to get nivolumab and we have different dosing schemas for pembrolizumab to make FOLFOX feasible in this population. And I think we have one more case. This time it's an esophageal squamous cell carcinoma. So this is a woman with a history of tobacco and alcohol abuse who's 69 years old and diagnosed with enlarging left supraclavicular lymph node. That pathology revealed was poorly differentiated FDG avid lower/mid esophageal squamous cell carcinoma. And there was additionally a large gastroesophageal node. This patient had significant dysphagia. And further molecular testing revealed a TP53 mutation, microsatellite stability, a PD-L1 CPS score of 9. She seemed quite fit. So what treatment option would you consider in this patient?
Yeah, so this is interesting, right? She's a typical squamous cell patient with medical comorbidities, and for squam in particular, more so than adeno, I don't actually do standard sequencing, but it's nice that they know her TP53 mutation. She has no contraindication. In this to immune checkpoint blockade, in my clinic, this patient would get chemotherapy plus immunotherapy, and I think irrespective of PD-L1 status.
Irrespective, then which would you use these days?
Yeah, so I have again been using most of the data for Keynote 590 and so forth is with high dose cis, which obviously is very difficult for patients in her state. So I typically use oxaliplatin in combination with 5-FU, although data coming out of China makes it very tempting to use a taxane in first line setting. This is not our practice. Typically in squamous, we prefer 5-FU platinum. And then I decide whether or not I want to use pembrolizumab or nivolumab. Sometimes I'm able to get nivolumab even for the patients already. But it really is, I think, in most practices where if your use is restricted, then pembrolizumab, platinum, and fluoropyrimidine would be the best option.
Completely agree. It's really more of a feasibility question with your chemotherapy backbone than any data existing right now that suggests the efficacy between pembrolizumab and nivolumab. And then it goes back to the question that we talked about before, though. Would you, in this fit 69-year-old, consider this chemotherapy-free backbone if they were asking for it?
I would have to see the scans. Maybe. I could be convinced to do a nivo-ipi, but I would be very nervous to do that again because of this concern for rapid progression, and then you may not have an opportunity to use treatment in later lines of therapy. I think one point we want to drive home is that all of these immune checkpoint inhibitors, anti-PD-1 therapies, are very similar in terms of efficacy. You just have to decide how you want to use them in clinical practice based on schedule and other preferences.
And once I'm hearing that she has some dysphagia, it does make me think twice about using that approach. Uh, you really need that deep response, because that deep response is the difference between her being able to eat food and put on weight, get back to normal performance status, versus needing, if possible, stent, or sometimes even a peg placement. And the goal is really to get people back to their baseline. So I really try hard to get treatment in quickly with the chemotherapy-based backbone, get them eating without needing these invasive procedures. So now that we've reviewed the landscape for both esophagogastric adenocarcinoma and esophageal squamous cell carcinoma, just to summarize, for first-line therapy in the U.S., we have FDA approvals of nivolumab and chemotherapy per checkmate 649, and then pembrolizumab with trastuzumab and chemotherapy for those with HER2-positive gastric and GEJ adenocarcinomas. In squamous cell carcinoma of the esophagus, we have approval for first-line pembrolizumab in conjunction with chemotherapy, with approvals for checkmate 648 of nivolumab with chemotherapy, as well as nivolumab and ipilimumab without chemotherapy. Whereas in the second line, for patients who haven't already received PD-1-directed therapy, there's approval for nivolumab for esophageal squamous cell carcinoma for attraction 3, as well as pembrolizumab for those with a CPS 10 or greater with esophageal squamous cell carcinoma, microsatellite unstable tumors, or TMB of 10 mutations per megabase or greater.
Thank you for joining us for today's discussion and updates of immunotherapy, or where we are in the field of upper GI tumors. There's been a lot of excitement and many treatment practice-changing studies. It's important to remember that both immunotherapy with nivolumab and pembrolizumab can be used in standard practice for adenocarcinomas with HER2-positive and for HER2-negative disease. One important reminder is to continue to test for biomarkers in this population to understand how to best use combination strategies, both in first line and then second line in subsequent studies. So thank you for joining us, and have a great day.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/NTS860. This activity is supported through educational grants from Bristol Myers Squibb and Merck & Company Incorporated.